I wanted to share a quote from the husband of a donor to start off our presentation. My wife's donation was important to our entire family at the end of her life simply because she had to die. We do not know why it happened, but it came with a truly significant and meaningful statement. She will live on. The reason I wanted to share this quote is because of the legacy donors leave and the comfort it brings to families. Our outline today, Boris will be presenting on MAID law currently, MAID process within BC, the difference between Track 1 and Track 2. I'll be presenting on organ donation following MAID all-encompassing, the waitlist in Canada, organ donation following MAID timeline here in BC, statistics, referral and eligibility, and then we will circle back to Boris to give a provider perspective on donation with MAID.
Thanks, Bobbi. Hi, everyone. I'll give a brief overview on some of the criteria we use to determine eligibility. Certainly, we can go into more depth with some questions, but for the meantime, just cursory. Eligibility is for individuals who are of 18 years or older, obviously capable, that is, having the capacity to make a healthcare decision on their own behalf. It has to be voluntary. Obviously, we check for coercion or any pressures that are undue. Informed consent of other means of alleviating their suffering. Every single one of our patients has a thorough discussion on other alternative options, including palliative care, hospice care, palliative sedation, and all the other areas of medicine that might be able to impact on their suffering. We'll go into a bit more of a definition on this grievous and irremediable medical condition as it pertains to both the Track 1 cases and the Track 2. So what is grievous and irremediable? Serious and incurable illness, disability, or disease, and an advanced state of irreversible decline in capability. Excuse the acronyms, and no one uses them. Enduring physical or psychological suffering that's intolerable to them and cannot be relieved under conditions they consider acceptable. These are all legal terms, not necessarily medical ones. And the way that we interpret MAID is through legal understanding rather than a medical one. And I'll get a bit more into that as well. So what's the process within BC? The first step is the patient inquiry. This can typically happen, in the community with a GP or nurse practitioner, primary care clinician. Sometimes it's allied health and in many cases, actually, predominantly allied health, especially within hospital settings. And it actually can be patient initiated. There's no clinician referral necessary for a MAID. This can be done online where patients get the information for the associated ADP office. Every single health authority has one, and they can inquire themselves. They request MAID through a specialized form that creates a formal process. These forms go to the health authorities, and it's the responsibility of each health authority ADP office, the assisted dying program, to then figure out the assessors for these individuals. It's a minimum of 2 assessments per individual, as long as both assessors find the person eligible. However, this can be more than 2. If patients are found ineligible by 1, they can request additional assessments. This can be the primary care clinician plus one of the members of our team. But in many cases, it'll be members from our team that are selected for both the assessment as well as the provision. So both assessments done by our team. And then they have an assisted death, and this can vary quite widely. We go into any space that allows us to, so certainly hospitals, hospice settings, palliative care settings, most often in people's homes, in the rooms that they've known, in their bedrooms, in their backyards, wherever they find to be the most comfortable and peaceful setting for themselves. Often it's a lot of family, a lot of friends. We can have quiet affairs, but to be honest, I've seen everything under the sun. I've seen catered events, I've seen big ceremonies, poetry readings, storytellings, generations of family present with the individuals. And then after death care. And throughout this continuum, they're still followed by the regular healthcare team. A lot of individuals who come to MAID are still undergoing healthcare decisions, active treatments, palliative or otherwise. And so each of these individuals has safeguards in place in order to protect their individual rights, but also to ensure that the laws governing MAID practice are kept in place. And these differ between the 2 different tracks, and we'll have a brief overview of that. So we have Track 1s, which have been well established in Canada and have been since the inception of MAID law, which are individuals who have a naturally foreseeable death. That's a death that has a a trajectory towards an end. This could be something like dementia, ALS, cancers, where we understand that the disease itself is life-limiting. Although there have been some modifications to the law, including the abolition of that 10-day reflection period, there is still some criteria that governs it, that restricts it, but on the whole, there's very few restrictions as long as these individuals are deemed eligible. They have no waiting period. There's no need for expert consultation, and they can have a waiver of final consent, which would allow the provision of medically assisted death in the event that in the future, following the assessments, they lose capacity to consent. Contrast this to our non-foreseeable deaths. These are individuals who certainly have a physical ailment that causes grievous and irremediable suffering, but for whom there is no end that one can foresee. The disease itself is not terminal or life-limiting. These individuals have a much more rigorous process in order to go through the MAID provision and in fact, in order to be found eligible. And we talk about a minimum 90-day assessment period. This is a minimum. Often it can take much longer to determine whether or not these individuals are eligible for a MAID. All of them require consultation with an expert. That is an expert in the disease in question. So if an individual has a particular disease that would require neurological specialization, it would require the MAID physician or nurse practitioner to consult that neurologist or at least an expert in that particular area. And then the individual has to have awareness of all the other means to alleviate their suffering, what potential treatments are available, what treatments have been offered, why or why not those would be reasonable to the individual. Unfortunately, these individuals cannot have a waiver, but typically speaking, they're not at any risk of losing capacity as their diseases aren't typically ones that are acute or have acute consequences in the short term. Reasonably foreseeable, and this is why I talk about MAID as law. So rather than medical understanding, we really have legal precedent-setting understanding. So often what happens with MAID is there's iterative changes depending on what is brought forward in legislation. Individuals will seek a medically assisted death, and for whatever reason it might be contested. And then new laws are developed in order to understand the definitions that govern MAID. One of them would be the reasonably foreseeable. So a disease can be terminal without necessarily being imminent. That's a really important one. A lot of individuals think that MAID is for people who are facing a death within 6 months, but truthfully, a person can be diagnosed with something like ALS and survive years with an understanding that there is no cure and they will certainly succumb to their illness in the future. And just to briefly highlight the differences in the complexity of these cases, a track 1 case might be an 82-year-old individual with poorly controlled diabetes, has already had an amputation for a vasculopathy, now undergoing a subsequent amputation for complications further along in their illness. They're telling their healthcare team that they just don't want to do it. The first amputation was an enormous ordeal for them, an enormous recovery period, and they just don't have it in them to go through that process again. And they're telling us that they would prefer a MAID than to undergo that procedure again. Contrast that to a 46-year-old with severe osteoarthritis of both knees, incredibly complex medical history with certainly some risk factors for an operation and some consequences to the rehabilitation process because of those complications and that complex medical history, refusing the joint replacement, stating that they just wouldn't want to undergo the rehabilitation and concerns for decreases in functionality and quality of life. Certainly, this individual doesn't have a life-limiting illness, but one could absolutely understand the suffering that they'd be undergoing. Although I don't want to get too much into the numbers, I'll leave that for the leadership team with MAID. Trends in MAID are quite clear that since its inception, the per capita rate of individuals requesting it is increasing, and this hasn't been slowing down. Every single year, we see more people requesting MAID and more people undergoing the provision.
A growing number of patients who are requesting medical assistance and dying are also asking about donating their organs for transplant. Organ donation following MAID is currently performed in Canada, Belgium, the Netherlands, and Spain. The American Journal of Transplant published a study in December of 2022. The study was a review conducted in 2021, which showed Canada performing the most organ transplants following MAID among the 4 countries offering this practice. The data collected from the paper showed a combined 286 assisted death recipients providing life-saving organs for transplant to 837 patients in the years up to and including 2021. and Canada had performed 136, so almost half. This work is important because of our wait list. We're still not meeting demand. So Canadians waiting for life-saving transplants in 2022 was at 3,777. Of those, 527 of them were British Columbians. In 2022, we had 270 deaths waiting for organ transplants, and 10 of those were British Columbians. We have a piece of legislation called the Human Tissue Gift Act, which is meant for hospitals. It states that all deaths and impending deaths are to be reported to the donor referral line. We wanted to carry forward the spirit of this act into eligible impending deaths in the context of MAID. We have a universal referral process that ensures consistency with the Human Tissue Gift Act for all eligible MAID patients, allows BC Transplant to check patients' registry status, and ensures all patients are provided with the option of organ donation as part of their end-of-life planning. I wanted to take you through the journey and evolution of donation following MAID here in British Columbia. So in June 2016, MAID legislation passed in Canada, and in 2017, we had our first donation in BC following MAID. This was patient-initiated request, and the general trend up until 2020 was that all requests were patient-initiated. This meant that patients had to have awareness prior to making the request for donation. In the summer of 2020, BC Transplant and the Ministry of Health provincial working groups met to start discussions on rollout. These discussions were how to integrate the option of organ donation into end-of-life planning. The goal was for all eligible MAID patients to have the same equity and access. BC Transplant went to MAID steering committees in individual health authorities and started discussions on how to integrate organ donation with eligible MAID patients. An eligible MAID patient is a MAID patient who's had 2 approved MAID assessments completed. In January of 2021, we took the feedback and information and work from the 2020 group and rolled out our universal referral pilot program on the island. We chose the island because we had strong working relationships with MAID providers, and they had a high volume of MAID. We created our referral form, and that was so that providers could send this to BC Transplant via email or fax once their patients were eligible. We did education with provider groups to introduce the form and when to refer to BC Transplant. And shortly after the rollout in Viha, we extended the rollout to the rest of the province. This form can be found on our website under Organ Donation, Medical Assistance in Dying. On the form, we have our exclusion criteria. So for solid organ donation, the exclusion criteria include HIV, greater than 80 years, and metastatic cancers. Exclusion criteria for eye donation were ALS, MS, Alzheimer's, Parkinson's, and greater than 75 years of age. The implementation of the formal referral process saw an increase in referral rate of 90%. Although we didn't see an increase in utilized donors, this was for various factors such as medical eligibility and also having to have their provision in hospital. In April 2021, the Ministry of Health added options for organ donation discussion to the Health Form 1634, which is the prescriber form. We worked with the Ministry of Health to add the option to the prescriber form to serve as a reminder to offer a conversation with BC Transplant regarding organ donation as part of end-of-life planning. We attended provincial town hall sessions to provide education to providers and coordinators. This is the 1634 form under Section 11, where we find the option of organ donation or discussion for organ donation with BC Transplant. After adding organ donation to the 1634 prescriber form, we saw an increase in referral rate of 137% and an increase in utilized donors of 400%, from 2 utilized donors to 10. 1 year post the Universal Referral Program being launched, we acquired feedback from MAID providers and coordinators. The feedback was as follows: to change the wording from open-ended to a yes or no on the prescriber 1634 form. Patients were not necessarily secondly assessed by the provider, so the provider was having to go back and reach out to their patients again once they knew they were eligible. Many providers and coordinators felt that the option of organ donation was in the wrong place, that this should be added to the 1632 form, which is the patient initial request form. And it would say something along the lines of, if found eligible for MAID, would you like to be contacted if you were eligible for organ donation? As a consequence of this feedback, BC Transplant proposed the addition of the option of organ donation to the patient-initiated request form 1632. We had ethics review it to mitigate any concerns over patient requesting organ donation ahead of their assessments being completed. Although the patient could initiate interest in hearing about organ donation, we would not offer the discussion until both assessments had been completed and approved to maintain patient autonomy. January of 2023, the Ministry of Health added the option for organ donation discussion to the 1632 patient request form. Under Section 1 on the 1632 patient request form, we can see the option to discuss organ donation as part of end-of-life planning added. So patients who are approved for MAID with 2 assessments would be offered the option to speak to an organ donation coordinator or to an eye donation coordinator as part of their end-of-life planning. Referrals would come into BC Transplant via MAID coordinators, GPs, MAID assessors, providers, and patients. Referrals were faxed and emailed to BC Transplant coordinators. Adding the option of organ donation to the 1632 patient request form saw an increase in referral rate of 43%. Although our utilized donors didn't increase, more patients were being offered the option of organ donation as part of their end-of-life planning, which was the intent of this work. Currently, in 2022, BC Transplant and the Ministry of Health and nurse practitioners of BC put forward a request to allow nurse practitioners who are also prescribers for MAID to declare death in the context of organ donation following MAID. Presently, only physicians can declare death in the context of organ donation following MAID. In 2023, the amendments received royal assent. BC Transplant is working with all health authorities and the ministry to take the act to cabinet, to have the amendments enacted, and we anticipate it should be passed this summer. Currently, nurse practitioners cannot declare death in the context of donation, but when enacted, BC Transplant will inform MAID programs and provide education. The results of all this work from 2016 to the end of April 2024 this year, we've had 263 referrals, 34 utilized donors, 4 additional consented but not recovered for various reasons. We're also able to recover 5 sets of islets for research and 4 eye donations. 106 people received a transplant since 2016 due to 34 MAID donors. We were able to transplant 65 kidneys, 20 lungs, 19 livers, and 2 islets. I just want to take a moment to say thank you to the MAID coordinators, providers, assessors, and social workers. We would have never been able to achieve these numbers without your help, and it's been such a privilege to work hand in hand to make this happen. The utilized donors by disease were largely neurodegenerative and neuromuscular, followed by chronic pain, glioblastomas, and C2 quads. This chart illustrates the growing number on the far right-hand side of patients who are undergoing MAID in BC. I think this chart just shows the opportunity we still have to potentially continue to work with the ministry and MAID programs to integrate the option of organ donation and make sure all eligible patients are being given the option of organ donation as part of their end-of-life planning. So organ donation after MAID process, it largely looks like a deceased donor in the ICU. However, all the workup is done in an outpatient setting. Referrals come in via fax and emails to BC transplant coordinators. We review medical eligibility and then let MAID coordinators and providers know whether their patients are eligible. We meet with patients in our office, in the community, at their homes, and are transparent about what the process will look like for them. If they wish to move forward, we go through a formal consent, followed by a medical social questionnaire, and then start booking their organ function testing in an outpatient setting. These tests include chest x-rays, CT scans, lab work, cultures, and then we discuss logistics. The provision must happen in hospital, so we discuss which hospitals are able to provide this service. On the day of provision, patients are admitted 1 to 2 hours prior to their provision time. We follow a modified DCD process. Declarations are done by 2 physicians currently, following their MAID protocol. Once we go through declaration of circulatory death, they move to the operating room following a DCD protocol. The spaces we use are close to the operating room. We try to make them as less clinical as possible, so patients are allowed to have as many family members as they'd wish, bring pictures, music, blankets. We've had LED candles in the room. However the patient envisions their end of life, we try to make happen in the hospital setting. I wanted to just end with another quote. My father is still helping people even in death. I would tell the recipients to please enjoy this gift and know that the person who gave it to them was an incredibly special and loved person. They have part of the best person I've ever known with them. I wish them health and happiness and many days ahead. Daughter of a donor. And with that, I will hand it over to Boris to give a provider perspective.
This next part is much more about how I see the differences, contrasting the two of organ donation death and a MAID death. I certainly don't want to posit one as a negative or a positive, more just to highlight the sacrifice that people make in order to make this happen and how important it is to them to give this gift. The patient we'll use is one that I've modified a bit, but was the first patient I ever did an organ donation MAID death with. This was a 46-year-old individual, young family with a new diagnosis of ALS. They'd been doing well enough on their illness for close to a year, but had been having much more mobility issues with lower limb disease and had since been mostly confined to bed. They'd been having many more falls than typical, and at one point had been found by their very young daughter on the ground. At that point, they decided that the disease had progressed enough that they really didn't want to see anything further. They felt it had become the best possible balance of quality of life and time with their family that they were willing to endure. And all of this in the context of really wanting to move forward with an assisted death and provide organ donation. It had been clear from the outset that this was very important to this individual. In order to frame this, I'd really like to go through the process within BC, but this time from the organ donation lens. So the patient inquiry, and just as we had said before, the requests were made, the assessments, the death, and then aftercare. So when does it first start? We first start talking about it during the assessment portion, but certainly decisions aren't always made at this time. Some individuals have a very clear goal in mind, and they tell us right from the onset that this is important, and this is certainly something they want to work towards. Often this isn't the case, and individuals really just want information when we first talk. And to be quite frank about it, the discussions when we're having the assessments are already quite heavy. and a lot of detail and questions that can be quite overwhelming for individuals who really don't have the space to be thinking about too much. So often what will happen is this becomes a continuous conversation with iterative changes to the patient's outlook in terms of organ donation based on how the conversation goes and really how their treatment goes. And so really it's about planting that seed, providing the opportunity for individuals to explore this as an option, especially if it's important for them, and really giving them the space to consider it and to follow up with us when they deem necessary. I only really ever ask the question once. I provide all that information, and then I allow the patient to be the one to make the decision and drive that forward if they wish. So why is it so important to really consider, and Bobbi already alluded to many of the ways that we make space for individuals who are giving organs and made to have the death that they wish, but there are some factors that we're really just not able to reconcile and do become quite a burden for our patients. One, they're more than happy to carry because this is important to them and they want to do this for other individuals. But I highlight it because I really want us to appreciate the fundamental impact this has on a person and why it's so important for us to support them in this. The number one that Bobbi said was the hospital setting. Most of the individuals that I've ever had a made death for really don't happen in hospital. It's in their homes, their favorite chair, in bed with their loved one holding them. These moments are very special to not only the individual patient, but to their families in a place that holds a lot of memory for them. Contrast to this to a PACU setting or a hospital setting where there's quite a lot of machinery, and any one of us could understand quite the difference between having that last moment there and somewhere else. The testing requirements are quite rigorous for patients, including just before the provision, having blood testing. Obviously necessary, but certainly something that patients consider when they're undergoing the organ donation. A lot of coordination, a lot of meetings, a lot of ongoing discussions to work things out with family, logistics, help the families understand what the process is going to look like, preparation so that they understand every single step and the key role that every single step plays in the organ donation. The made medications will differ. What we had originally been using was bupivacaine in order to cause an arrhythmia. This isn't typically used in an outpatient setting, as there's really no need for a hastened death. We pronounce using just a pulselessness. However, for the purposes of an organ donation, we need asystole for a certain period of time, and it becomes quite important to hasten the move to asystole in these individuals. We began using KCl for this purpose, which acts much, much quicker. And we'll talk about also how that impacts the family's experience with the provision. Monitoring the provision, so obviously they have to be set with a monitor. We watch the ECG for asystole, and once asystole is declared, then we have to watch for another 5 minutes before we can declare death. Death has to be declared by 2 individual clinicians. As Bobbi had alluded to earlier, it has to be 2 MDs. However, that's being switched over to now to include the NP. This is also a large impact because MPs do the bulk of made work in this country and cannot participate currently in the BC donations, meaning there will be 3 clinicians, the NP doing the provision, as well as 2 MDs declaring the death. And family attendance. One of the biggest impacts I remember for the individual in question was really the family. I remember that the children didn't end up coming. It was the spouse of the individual. However, what ended up becoming really salient was the differences that happen when someone's in a hospital setting with organ donation. One of the most beautiful things I've ever seen with an organ donation, especially between partners, is a lot of touching and holding. Sometimes that individual is even in the arms of that person. That can't happen in an organ donation setting. The individual is in a hospital bed, and as soon as the medications are administered, we can't allow any touching. The reason is because any kind of touching will cause potentially an artifact in the ECG. And if we're in asystole and counting down the minutes, that resets the clock. And that has serious consequences for ischemia and organ donation quality. So as soon as the medications are in, it's hands off, and we're all sitting there watching the monitor. In addition to that, one of the most difficult parts of a death for the family is waiting for it to be over. There's quite a lot of buildup in tension when one's watching their loved one die and when one actually declares that death. That needs to happen over a larger span of time and in a quiet setting where really there's no ability to have that human side of the death. And often, we even talk about whether or not families can participate fully in the event or whether we ask them to leave a little bit earlier. So there's a lot of differences when it comes down to what it would be like for a patient undergoing those final moments with their family, a large consideration of what they want their final moments to look like, how we as an organization working in partnership with our BC transplant team to facilitate the most human provision possible in line with what this person would want, while also facing the reality that we're not going to be able to reconcile all the factors that detract from the beauty that a made death can offer a patient and the final moments that they have with their loved ones. So truly it comes down to the day of the provision. But what we hope to do, and certainly what we strive to do currently, is talk to patients about how we ameliorate those issues and how we work together to provide that death. In the end, I think what really comes down to it is how important is this for an individual. I've met some really brave people in my life who talk about how they understand that they're making some sacrifices and that it wouldn't be the way that they'd want it if they could choose anything. But it's an important enough decision for them that they'd move forward with it regardless of the consequences or regardless of the things that are barriers, because they want this to be their final gift, their final act. And their families understand that. And truthfully, whenever I hear it from families, they say the same thing, that they wouldn't have picked this as their number one setting, or certainly not the way that they would have said goodbye. But understanding, as you saw in that quote, that it's so fundamentally important for their loved one and for them to understand that this is what their loved one wants, which is really the essence of MAID, really meeting people where they're at and helping them fulfill their wishes as they see it. And for that, we'll leave you with any questions.
Thank you very much. That was a great presentation and gives a different perspective to things, Boris. Thank you. So we're open to questions in the room. Okay, Peggy, you go ahead and then I'll start working from slide. Oh, and please, turn on your microphone.
Great. Hi, everyone. It's Peggy John from Canadian Blood Services. Really great to hear your experience. It was fantastic to hear. Do you have a sense of the percent of declines because it's in a hospital setting? I didn't see that. Maybe you provided that and I didn't see that.
From the provider perspective, I really wouldn't be able to speak to it. To be honest, we don't necessarily collect those metrics. It's really anecdotal, but certainly that's one of the first things that comes up in the conversation. Patients' first question will be, what's the difference between this death and one that's not an organ donation? And that'll be the first thing that I mention, is that it'll have to be in a hospital setting. And the reason I do it is because Bobbi, as Bobbi had already mentioned, it's a really big decision tree for an individual, the setting that they're going to have it in.
I don't know if I can elaborate on that. Usually when patients are referred to us, once we describe how much outpatient testing we have to do, some of them are bed bound and this makes it very difficult. And they might decline for that reason. But usually once they kind of come to BC Transplant, their heart is really in donating and being able to provide this legacy at the end of their life.
Okay, I have a question for you, Boris. You mentioned in track 2, the patient is required to see someone who specializes in their disease process. What if there are treatment options, but the patient elects to opt out of these options? Can they still be eligible for MAID?
Thank you. Yeah, that's one of the more common questions. To what extent does an individual have to engage in their healthcare options? The simple answer is no, but there's a much more nuanced response than that. So an individual doesn't necessarily have to undergo the treatments being offered, even if they're available, but they certainly have to be aware of them. And more importantly, they have to be able to provide a rationale why they wouldn't do it. One of the best examples, and the reason I put it in there, was the individual with OA. So this was an individual who had already undergone a significant surgery for another ailment. And due to the comorbidities that they had suffered significant complications, some of which had led to their current condition. That individual was really able to express to me the experience that they had, the reasons why they wouldn't want to go another surgery, how difficult it would be to recover. And I saw in that individual a lot of insight into their condition, a lot of understanding about the options available to them. And that's what the law demands. It needs for individuals to be able to articulate why something is reasonable to them and why it isn't. It's the same that would be true of a track one, why some of our cancer patients opt to undergo invasive surgeries and chemo and radiation, and why others wouldn't do that depending on their goals, their values, where they are in their life. And we respect that same decision making with our track twos. However, the rationale needs to be there. It's not enough to simply say that I wouldn't do something. You need to provide the understanding to me and the other providers about why that doesn't align with your goals and your values. And in being able to do that, they can be found eligible.
Thanks, Boris. I guess, Bobbi, this is more for you. Are there a list of hospitals currently participating in organ donation after MAID?
We don't have a list of hospitals, but we work very closely with every hospital. We've done it at very small sites in remote areas to larger centers. These individuals want to have their end provision in their community, and we work really hard to support that. And from my experience, hospitals have been willing to support their patients and their community in providing this service.
Thanks, Bobbi. This might be for both of you, but do you find there's a significant difference with the family experience with the medication differences used in the context of organ donation and MAID? The idea that happening maybe sooner, that adds any anxiety to the moment, or is it reassuring that it will happen sooner?
In fact, that's one of the things we talk about the most. I think one of the hardest things I've had to see with a family is I'm struggling with a delayed cardiac death. This isn't in the organ donation setting, mind you. This is just generally out as an outpatient, which is why we even have bupivacaine as an option for individuals who are suffering from neurodegenerative diseases. They have quite strong hearts. They're usually quite young, and their death can be delayed to 15, 20 minutes. They can be apneic for quite some time before their heart stops. And we see in families this apprehension when they're watching their loved one. We don't want to delay that too much. I think waiting for that final moment can be quite momentous. And when you're waiting 20 minutes, it really feels like 20 hours. And so we start the bupivacaine on individuals in addition to the regular medications in order to hasten that death and allow for that final parting. The patient is already treated with propofol and midazolam, and they're certainly not suffering. It's more for the individuals watching. However, in the organ donation setting, there's those two elements. Really, it's the organ function and health and the potential ischemia resulting from the delay, as well as that delay in providing that cardiac arrest and death. And bupivacaine certainly wasn't doing a fast enough job of protecting both things. And so KCL was changed in, and because it provides both it provides a faster arrhythmia and asystole, we found it really meets both those factors that are needed really to support the families in saying goodbye and making sure that we can move towards a cardiac death that allows for minimal organ damage and ischemia.
Thanks, Boris. I have a couple more questions here. I don't know if there's any from the room. I just want to ignore people here, but okay. All right. Okay, so where do the referrals come from most commonly? Specialists, family doctors, patients?
To be honest, again, a metric that would be really difficult for me to say. We have health authorities all over the province that are dealing with requests. Typically, it depends on the individual, but a lot of them come from the community and from hospital settings. So one of the unique things about MAID is that it's not clinician oriented. So it doesn't need to be a clinician on the referral form. It's a self-referral. So you can go online, find these forms, print them out, and send them along. In addition to that, a lot of individuals find out for the first time in acute settings, and it'll be that allied health team, social workers, OTs, PTs, that are really helping individuals figure out the logistics and send in the forms. So we see it from everywhere, GPs, NPs as primary care clinicians, specialists treating terminal illness such as our dementias, our ALS, our cancers, and allied health team. So it's really from every walk of life in medicine and allied health.
Thanks, Boris. This one's probably more for you, Bobbi. Can you talk to what type of support is provided by the BCT to hospital staff for donation after MAID, especially in sites where they don't do this sort of thing frequently?
Every health authority has an in-hospital coordinator, so we meet with staff often several times before the actual provision day to provide education. We provide debriefs afterwards. We also have, we're lucky enough to have Jordy, a social worker on staff, who can come to debriefs afterwards. And he also follows up with families, so I think staff are really comforted by the fact that these families have follow-up with our social worker when the case is done. We have a large group of coordinators who can come and support staff as much as they need. So in smaller sites, we've met with staff several times up into the day. We've gone to the hospital a day prior to make sure everything's sorted out before the provision day, and then debriefed with them after.
Thanks, Bobbi. Okay, the last one I have here at the moment is there's been an increase in the number of organ donations after MAID, but there still seems to be more opportunities potentially out there. What do you suggest we do as healthcare professionals to help bring the awareness?
You know, I think, and again, so I don't have any evidence to support this. This is just an opinion, so that's the caveat here. But I think as a whole, I think a lot of us struggle with talking about end-of-life care. I think that's very commonplace, not only when we have MAID discussions, but really discussions with patients in any setting, talking about the reality that patients really aren't going to be cured or they're not going to get better. And I think when it comes to MAID, that conversation becomes even more complex. You're talking about an individual who is hoping to end their suffering by ending their life, and that's already a difficult conversation for a lot of clinicians, regardless of their end-of-life discussions that are happening before that. So I think when we're talking about MAID, it's really hard for individuals to go beyond even just that discussion to start incorporating things like organ donation. Often when I talk to patients out in the communities, they don't have too much knowledge about MAID, and it's not to say that their clinicians or their healthcare teams are unwilling to talk about it, but maybe they don't even have the information available to help educate them. And so when I'm coming to talk to them, the emphasis of my discussion is really on their wishes. I have my own particular job to do, which is to ensure that the law is put forward, that individuals are found eligible, that I'm minimizing risks to the patient, such as loss of capacity. And as I was mentioning earlier, the conversation is already quite complex and overwhelming for people. I think if we can start to have these conversations early, in much the same way we have goals of care discussions, we can start talking about options well before a patient even has to consider it. I think that's very much what happened with organ donation in the first place. People start talking about organ donation. We talk about becoming registered when people are young, when people are I was renewing my driver's license the other day, and there was a form right there saying become a donor. I think having these conversations early and aligning them with the way that this country is moving, which is that MAID is becoming much more prominently featured in end-of-life care, is really just going to naturally move towards people finding that this is an actually option for them, and they're going to be thinking about it well before it ever needs to be something that they're actually considering for themselves. And it's not to say that we're promoting anything. I hardly believe that that's really the way that we conceptualize MAID. It's about making sure that people understand what their rights are and what their options are. And for a lot of people, and including sitting in this room, organ donation is important, and understanding the different ways that it can come about, the ways that you could be participating in this program from an earlier onset is going to just be helpful for everyone. So I think it's about that, incorporating MAID discussions in end-of-life care talks and goals of care talks earlier in life.
Yeah, I think people are sometimes shy to ask another thing of a patient, but really it's about patient autonomy and letting them make decisions for themselves, and maybe not having the information to provide for patients, which is why BC transplant coordinators are happy to meet with patients and be transparent about what the process looks like so that they can make an educated decision on how they envision their end of life. So we're there to provide the conversation and to be transparent, and really we're only asking for you to offer a conversation with us.
Okay, I found some more questions. You're not off the hook yet. So the first thing I want to ask is, where does the legislation stand on including mental health conditions in Track 2 patients?
That's been very clear. It's just been deferred. So 2027 will be the earliest that any legislation will pass, if in fact it does. At that point, there's really not much more that can be said or done about that. I think that's really a governmental decision and higher up, well above me. But 2027 looks like that's when legislation will be developed, and not necessarily legislation, really the safeguards that will protect the current legislation that's already in practice with track twos.
And the next one is there an opportunity in the future to have MAID done in the patient's home or at a place of choosing if they still wish to donate their organs? And mentioning that TGLN Toronto has done a couple cases.
Yeah, I just know of TGLN performing one at home. As far as right now, we have no plans. We're just trying to make sure everybody's getting equitable access to the option as of right now.
And it's not even necessarily at home. I think the more we can do to change the setting to become less, hospital framed, the better for the patients. I mean, we already do the same with end of life care. That's what a hospice is. It's the same level of care with nurses and physicians that can provide 24/7 care for individuals that need acute assistance with their suffering, but in a place that feels like home, that's more comforting, that's more warm, that allows for more space for the very things that made a person's life so meaningful to them. We just want to humanize things. So it's not necessarily about the setting, but how we humanize. So certainly we're always working towards that, and that's something that's iterative with every single provision and unique individual that comes forward, because to be quite frank, an individual's death is much like their life. You really see a lot of personality come out and what someone would want for themselves in their final moments, and we're just trying to figure out how to meet them where they're at.
Thanks. Now, Boris, this is for you. Do you experience providers not wanting to approach donation due to a feeling of conflict of interest in bringing it up?
No, I really don't think so. Do you know what's funny? I remember our ICU counterparts. I remember having a discussion with them and realizing that we're not so different when it comes to these discussions, that there always is a bit of a concern about how we approach the sensitivity of something like organ donation with families and with loved ones. In the end, it's really not about that. There's the realities of the situation. As clinicians, we're really just doing what we can to understand the patient's wishes. And insofar as having the discussion, we really just frame it, because this is what it is, a discussion about an individual's options and their rights. I don't think we shy away from the conversation. And in fact, MAID clinicians just by default are positioned in an area of medicine where we really can't shy away from anything. We really have to have all these very frank discussions with individuals about settings, locations, medications, eligibility criteria. And so I don't think that's necessarily the stopgap. And I wouldn't call it a conflict of interest. Our interest is in alleviating suffering, and we certainly strive to do that in every attempt. And then for a lot of individuals, the idea that there's a part of them that'll live on, that there's a gift that they can give, that there's something that they can do to impact someone's life, even in their final moments, that can alleviate a lot of suffering and bring a lot of peace to an individual. So I find those things more than in line. I think by thinking there's a conflict of interest, they're necessarily thinking that what we're hoping for is that an individual will have a MAID death, but that's certainly not the case. I talk to many individuals and half of them never have a MAID provision. My goal is to make sure that this individual finds peace in knowing they have choice and power over those final moments and making a decision. And as long as I can do that, I find that my job is done. Whatever the decisions they make after speaking with me, for me, is irrelevant insofar as they do what's best for themselves. And so I don't see a conflict of interest, and I certainly don't think my colleagues find one either.
Thanks, Boris. This may be a point for Bobbi, but is MAID in a hospital setting required for eye donation?
No, so if you're just looking for eye donation, you can still have your provision at home.
Thank you. When patients go to the hospital to do testing, is there any cost? And if they need to travel for tests, is there reimbursement offered?
It's on a case-by-case basis. So with every individual, every case is individual, and we just try to support that person in their end-of-life planning. So it's difficult sometimes for these patients to make it to hospital for all these tests. So I try to lump all their tests in one day and one visit, or have lab go to their house to do these visits. And if there is a cost for travel, then we approach it case by case to support that patient.
Thanks, Bobbi. Boris, can you explain what the purpose is of the waiver of consent?
Yeah, I didn't do that justice. So for some individuals, the disease in question poses a serious risk to their ability to consent further on. And what I mean by that is the law mandates that we do something called final consent. So regardless of the assessments, when they occurred, or how we found the patient eligible, that same individual in the future, on the day of the provision, has to provide consent one final time. We call that final consent. So before I give the medications, immediately before I ask the patient, do you give me permission to end your life with an assisted death? And that individual needs to be able to communicate to me that they want this. And that they're choosing this. Now, it doesn't necessarily have to be verbal. A lot of our patients are nonverbal by the time they reach us. I had one patient who had had a stroke just before the provision, who squeezed my hand twice for no, once for yes. So we find ways to facilitate this communication, but that also highlights an example of why patients are at risk. This individual had a cancer, and they're much more likely to have a stroke, have a metabolic abnormality that's going to result in a delirium or a coma. And these individuals don't want to lose the ability to move forward with an assisted death. So they sign these forms, which specifically state that the individual signing, so that would be the provider in this instance, has permission to administer medications that would end their life in that instance. These have a timeline to them, so the expectation is that we're planning a MAID provision and that this is just a bridge to get us there in case something happens in the interim. Patients want to have family come over from overseas or want to facilitate certain documentation before they go, such as wills, and things are being delayed for those purposes, and we want that waiver to make sure that this right is protected for that individual. Now, for our MAID Track 2s, these individuals aren't necessarily suffering from diseases that are going to result in an acute loss of capacity, but that's not always the case. But these individuals can't sign a waiver of final consent. They have to provide final consent on the day of, with capacity, no exceptions currently. Although that might change in the near future, that's certainly the law now as far as MAID waivers.
Thanks, Boris. There's a question here, a few people are wondering if there's any evidence of harm to organs from the MAID medications. Yeah.
No? I guess both, yeah. Yeah, none that we can see. You know, what we're really discussing is just the typical organ damage, which is ischemia. That's the number one reason organs suffer, and the number one reason there's going to be issues further down the road post-donation. And that's the ongoing discussion. We don't donate hearts currently with MAID, so I couldn't, I think as an antiarrhythmic is concerned, we don't have much knowledge about that. There certainly could be, but again, that's a question well above me. You'd have to ask an anesthetist or a cardiologist. For me, there doesn't seem to be any concern about that now, but I think if we move along and start to talk about cardiac donation, certainly we'll have to have the conversation about the antiarrhythmics like KCL or the bupivacaine, but currently there doesn't seem to be any concern. It's really just about hastening cardiac death to ensure that we're not damaging the organs with ischemia.
Thanks. There's a sort of suggestion here about what about putting the options for organ donation in the My Voice book for advanced care planning? It seems like something that, and I know we are going to, go ahead.
No, I mean, that's brilliant. Like, it's exactly what I was alluding to earlier. I think rather than having the discussion of MAID with organ donation and trying to find some ways to elaborate on that, I think just having the discussion about organ donation in general, the minute we're talking about end of life, it begets a conversation about MAID. I think an individual has every right to understand that they have a MAID death as an option as they do a hospice death or a palliative death. And then once you align all those, you really start to see the same journey towards end-of-life goals, which is really, we're just trying to talk to people about all the things available to them and talk about all the things that might be important to them. So I think it's about that, like have the discussion about organ donation early, have the discussion about goals of care early. MAID is really just another option in a goals of care discussion, and organ donation is an option in a goals of care discussion.
There's a question, a few people were wondering about this. How do you approach MAID requests out of institutions that have religious-based objections?
Sorry, say that again?
When there's requests in an institution that does not provide MAID because of religious purposes?
Oh, we work well with all our community partners. The truth is, we make no judgments in terms of whether or not an individual can or can't have a MAID provision in particular or spaces, especially when there are things like hospices or hospitals. I mean, certainly it would be my wish that we could provide in the patient setting because it's the most comfortable with the patient. I don't know if you've ever seen transport, what that looks like for an individual that's suffering grievously and acutely from their illness, but it's never something that we'd wish upon anyone. But we're respectful of one another. These individuals make space for us to have these assessments. There's certainly no barriers to us having a discussion in these facilities, and then we work with all our partners to try and facilitate a transfer. I do hope for the day that really this doesn't become a barrier to individuals, really for the patient. I think more than anything, and the same reason we talked to Bobbi about humanizing things, is just to keep things patient-centered. I think the importance is making sure the patient's comfortable, that the patient is in a setting that they find aligns with their goals, and that we're really facilitating the least amount of suffering for that individual. But right now, we can go into any of these facilities and have that discussion with patients and figure out what their goals are.
Thanks very much. So the last question I think you sort of covered, but it's how is consent provided by dementia patients? So.
Oh, yeah. And so this is why I talk about having these discussions early. You know, you'd have the same discussion with an individual about dementia well before they ever have severe dementia, which is, would you ever want to be in a long-term care facility? What would that look like for you? What does dementia look like for you? Do you want to be at home? I mean, these are normal discussions to have with anybody. You really want to understand what a patient's wishes are. And in fact, that's what ends up happening with me. These patients come to us quite early in their illness. And I say the same thing about an ALS patient. Certainly not true in every single case. I've spoken with ALS patients who are already invasively ventilated and being kept alive, you know, with significant intervention. But most of the people I talk to are really early in their illness. They're still mobile, they're still talking, they're still, you know, able to do most of the things they want in their life. But they foresee what is coming. They understand the trajectory of the illness and what's going to happen later in the future, and they want to have some power control over it. And the same is true of dementia. Most of the dementia patients I talk to are still early dementia. Certainly they have cognitive deficits and function is impaired, but not to the extent that they can't make healthcare decisions. And in fact, most of them are already well versed on what MAID is and what dementia is, because their family members have had it and they know what they want for themselves. And so those conversations are easy. Certainly, I do find the individuals who come later on who are severely suffering from cognitive deficits due to their dementia. And unfortunately, I have found patients incapable. I tell them that I understand that, you know, they're able to convey to me that they certainly don't want to live with their illness anymore, but they really don't have the ability to help me understand why, particularly with their insights on their illness or what's happening to them. And so these individuals can't be found eligible. But most of the time, especially now that MAID has been in our country for so long and people know it, they come to me early, which is what I encourage. I don't think there's any negative to having the conversation early, in much the same way we start having a green sleeve conversation with people when they start, you know, in their 40s and 50s, start testing for chronic diseases like diabetes, is because you want to understand that you can't plan for these things, and you just want to understand what a person's wishes are well before you have to make that decision acutely. And that's the conversation now. Most people I talk to are coming to me because they've talked to their friends. They're in facilities where they're having conversations with people their age who know somebody that's had a MAID or know somebody that's gone to a facility they wouldn't want to otherwise. And we have those conversations early.
Thanks very much. I don't know if there's any last minute questions here, but I want to thank everybody who asked questions over Slido, and thank you very much, Bobbi and Boris. Great presentation. So we're just going to give you about 10 minutes to get up, stretch your legs, so I can